Hi, and welcome back to Dorky Docs. The focus of the video this week will be regarding headaches. Headaches are a very common presentation to general practice, and differentiating the severe, acute presentations to the more chronic headaches we often see in community is essential. Additionally, you're more than likely to be questioned about this in your exams. It's worth, however, going over headache red flags, which include a sudden onset thunderclap headaches, headaches with a neurological deficit, headaches with fever, meningism, photophobia, and a change in conscious state, headaches with visual loss or signs of intracranial pressure such as cough headaches or papilledema all need urgent attention, and these would often indicate more sinister pathologies such as acute intracranial bleeds, infections, tumours, and basically need to be admitted. Moving on to the more routine, let's start with tension headaches. Tension headaches are common and typically present as a tight band-like sensation around the head, often bilateral. They tend to be of a dull intensity and can be related to stress or anxiety. Chronic tension headaches, however, are defined as tension headaches more than 15 days a month. In terms of management, NICE 2012 recommend a simple analgesic approach, be it paracetamol and NSAIDs as first lines, with some suggestions that alternative techniques such as acupuncture also being beneficial. Cluster headaches are extremely painful headaches that, as the name suggests, happen in clusters, with each episode often lasting only about an hour or so, but repeats over a period of months. The pain is often sharp and stabbing, revolving around the eye and eyelid swelling. Redness and nasal symptoms are often usually present as well. In the acute setting, however, high-flow oxygen and triptans subcutaneously are usually first line, with verapamil seen as a preventative measure. Another diagnosis not to be missed, particularly in the elderly, is temporal arteritis. This is a vasculitic headache that is closely related to polymyalgia rheumatica. These typically present in over 60-year-old patients with a period of weeks to months of headaches, jaw claudication, and sometimes even visual disturbance on the background of non-specific symptoms. The visual disturbance is because of ischemic optic neuropathy, which usually needs urgent ophthalmological intervention. Classically, there tends to be a painful, palpable temporal artery, with these patients also having a classically raised ESR, with CRP tend to be relatively normal. A temporal artery biopsy is often confirmative, but because of skip lesions in the pathological process, often false negatives are found. The treatment, however, is relatively straightforward in the community, with high-dose steroids plus an urgent eye clinic review to rule out any ischemic optic neuropathy. One large subtopic within headaches is migraine, something you'll often come across in your clinical work and in most postgraduate exams. Classically, migraines present as a unilateral, severe headache with classical association of nausea, photophobia, and phonophobia, and tend to last up to 72 hours. A patient will often need a dark room or use sunglasses to help with the photophobia. Some patients present with an aura, which is a visual disturbance, usually as transient scintillating scotoma, in what is known as a classic migraine. There are a number of triggers for an attack, which include stress, exhaustion, alcohol, cheese and red wines, and the combined oral contraceptive pill. In terms of treatment, oral triptans, paracetamol, and non-steroidal anti-inflammatories are first line, with nasal triptans preferred for younger patients. The addition of metclopramide or prochlorperazine could also be considered. First-line prophylaxis for migraine prevention is topiramate and propranolol, with the latter preferable in pregnant patients. In pregnant patients, in terms of treatment, paracetamol is seen as first line, with NSAIDs only really used as second line in the first and second trimesters. Given their teratogenicity, aspirin and codeine are typically avoided. A few extra points. The combined oral contraceptive pill is seen as a contraindication if a patient is having a classic migraine, i.e. a migraine with an aura, given the increased risk of stroke and VTE. Additionally, it's safe to use an HRT, but counselling with the patient needs to be undertaken, as the use of HRT may make the migraines worse. I hope that helps in a whistle-stop tour of the common presentations of headaches. Remember, it's important to rule out sinister pathology first before agreeing a diagnosis and management plan with your patient. If this video helps, be sure to like, comment and subscribe. We've also got a Facebook group with the page below, so be sure to join the growing community there to keep up to date with the most recent posts. But otherwise, I'll see you in the next video.